which is on Gerd and Hiatus, hernias. And for that, our chairpersons are Dr. Sameer Baliga, Dr. Brundaban Nahak, and Dr. Vishal Gupta. I repeat, Dr. Sameer Baliga, no, Brundaban Nahak, Vishal Gupta.
Good afternoon, and we start this session. For first lecture, I invite Dr. N. Mohan for his lecture on indication for surgery in GERD, hiatus hernia. How far do we investigate?
Good evening, everyone. So, indications for surgery, how far you investigate. First, we have to understand the natural history of GERD. It can be a non-erosive reflux disease or mild erosive disease with easily healable esophagitis with PPI, or a severe erosive disease which are difficult to heal esophagitis despite on PPI therapy, or may progress to Barrett's esophagus and carcinoma. This can take anywhere from 2 to 20 years. Facts are PPI does not prevent progression of the disease, it only reduces the symptoms. And stages of GERD severity correlates well with altered mechanical failures of gastroesophageal reflux barrier. And damage to LES is associated with altered hiatal anatomy, increased esophageal exposure to reflux acid or bile. So our treatment goal is to eliminate symptoms, heal esophageal mucosa, prevent and manage complications, and maintain remissions. So the various mechanisms of mucosal injury has been proposed or is actually there, but for surgeons we are considered only on OG junction problems like frequent transient lower esophageal sphincter relaxation, hypotensive LES and hiatus hernia, but we have to investigate, rule out other causes which are not good patients to, the results are not good on anti-reflux surgery. So SAGES guidelines says indication for surgeries are patients who have failed medical management, decide on surgery despite successful medical management, have complications of GERD like Barrett's or peptic strictures, have medical complications attributed to large hiatus hernia, and have atypical symptoms with confirmed reflux on 24-hour pH monitoring. So anti-reflux surgery has the best results in patients who decide for surgery despite good medical management. But even failed medical management respond well with anti-reflux surgeries. So when you want to investigate, one, you have to investigate to prove there is GERD, and second, we have to investigate to exclude condition which can mimic GERD. This is very, very important because results of anti-reflux surgeries are very bad and patients are miserable with anti-reflux surgeries, especially like patients with achalasia cardia, esophagitis, infectious esophagitis, and functional esophageal syndromes. So for all these things, the common investigation is, apart from good clinical history, you have to have an endoscopy. Endoscopic biopsies will exclude infectious esophagitis and esophagitis. Should have a good pH and pH 24-hour pH and impedance, which can eliminate rumination syndromes and supracardiac belching. These are two very prominent patients who come with compulsive belching, and these patients, when subjected to anti-reflux surgery, are really become miserable and results are very bad. And obviously the functional syndromes has to be ruled out. So first investigation is OGD, where evidence of mucosal injury is established, like ulceration, peptic ulcers, and Barrett's esophagus. When there is a peptic stricture and LA class C and D is esophagitis, it is pathognomic of GERD and no need for further investigation like 24-hour pH. Also to look for hiatal hernias, and hernias should be measured craniocaudally and lateral dimensions. When to consider 24-hour pH? These are for typical symptoms, but they don't respond to PPI therapy. Patients who have atypical symptoms to confirm or exclude GERD. This is for documentation of abnormal esophageal reflux burden before any anti-reflux procedure, and diagnosis of functional heartburns and reflex hypersensitivity by exclusion of pathological acid exposure time, and diagnosis of supragastric belching with combination of pH impedance and rumination syndrome. Emerging indications are to monitor reflux burden following invasive reflux procedure and surgery, and also reflux burden following ablative therapy for achalasia. So 24-hour pH monitoring gives large amount of data, like number of reflex episode, longest episode of reflex, number of episodes which last more than 5 minutes, percentage of time spent on reflex in upright and supine position, and data Demister score is calculated, and abnormal distal esophageal acid exposure is defined as Demister score of 14.7 or higher. So the acid exposure time is the most important criteria, and not the number of non-acid reflux events, which actually predicts improvement in both medical and surgical treatments. When do you combine pH monitoring? pH monitoring and impedance, where the catheter is placed, impedance catheter, and the direction of movement of esophageal acid is calculated. Whether it's antigrade, it's a normal physiological swallowing, or it's a retrograde where you confirm it is a gastroesophageal reflux. And proximal pH sensor, when it placed, can detect acid reflux in patients with atypical symptoms. And one disadvantage is it's very sensitive and it overestimates non-acid reflux episodes, and reading this data is very time consuming. So 24-hour pH monitoring is essential for evaluation patients with non-erosive reflux disease, extraesophageal and atypical symptoms, and those who do not respond to PPI therapy. Patients with typical symptoms and esophagitis, as I told before, do not need pH study for further diagnosis and treatment. So when do you do manometry in patients with GERD? When you want to localize LES for appropriate placement of pH and pH impedance catheter, mainly to exclude major motor disorders, especially like achalasia, to assessment of esophageal peristalsis before any anti-reflux procedure, and again diagnosis of rumination cystinosis, supragastric belching, and evaluation of post-fundoplication dysphagia. So other emerging indications are to assess the morphology and integrity of esophageal OG junction and measurement of hiatal size. So what does this esophageal function testing implies, like endoscopy, manometry, pH monitoring, impedance, as just to create a GERD phenotypes which can guide us for management. And symptoms and PPI response alone do not adequately phenotype GERD into therapeutic categories. So OGD you have categorized into erosive or non-erosive disease, and with clear better symptomatic outcome from PPI therapy in erosive disease than non-erosive disease. And like GERD with class C and D LA classification are more consistent with evidence of GERD, and these patients respond to anti-reflux therapy. Again, pathological acid exposure time is a predictor of good outcome for both medical and anti-reflux therapy. Abnormal of acid reflux, acid exposure cohorts, patients who correlate with symptoms do better with anti-reflux procedures. Physiological and acid exposure with no symptoms, they perform badly on anti-reflux surgery, and functional problems has to be ruled out. So to conclude, what I say is to stop the progression of GERD, early recognition of symptoms and signs of progressive disease by taking good history, endoscopic examination, measurement of esophageal acid exposure by pH monitoring and impedance, and manometric assessment of LES, and early surgical intervention to correct LES abnormalities. Thank you.
Thank you, Dr. Mohan. It was a nice lecture. So before we start discussion, I just want to ask one question. Can you elaborate more on the indication? You have said the failed medical treatment. So what do you mean by failed medical treatment in terms of dosing and duration?
Yeah, actually there are a lot of flow charts available for the management strategies, diagnosis and other things. The thing is, first is symptomatology, and proving whether there is erosive gastritis or not on endoscopy, and whether they response to PPI. Initially they start with standard dose, and if symptom doesn't relieve, go for double dose PPI, and still they don't respond, do other esophageal function manometry like pH monitoring, impedance and manometry to exclude or diagnose other causes of which can mimic GERD.
I just need to ask, suppose in a known case, in a diagnosed case of erosive reflux disease, so what would you take as a medical treatment failure when you ask?
There are two concepts. One is patient initially responds to medical therapy, and the symptoms comes back once he stops PPI. And second, he doesn't respond to PPI at all in first place.
Second is, do you want to get the manometry to decide the type of rep? It is complete versus partial.
No need.
It's not necessary, or in some subset of patient, do you want to get the manometry like in elderly patient or patient predominantly presenting with the dysphagia, even when the barium is otherwise normal or endoscopy is otherwise
Definitely,
normal?
when there is a diagnosis in doubt and you are not able to characterize the GERD, what is the symptomatology doesn't correlate with endoscopic finding, then definitely pH 24-hour pH and manometry is essential.
Can I comment? I think there is Indian guidelines which are published in the Indian Journal of Gastroenterology, and that deals comprehensively with this subject of patient selection and all. And they recommend that the minimum investigation that are to be done are at least an endoscopy, manometry, and a 24 hours pH. And as far as the endoscopic grading of esophagitis is concerned, there is Los Angeles grade A, B, C and D. So grade C and grade D are severe forms of esophagitis, and they are diagnostic of esophageal gastroesophageal reflux disease, and these are more suitable candidates for surgery because they have severe reflux. Grade A and grade B esophagitis require further testing, and that is where a 24-hour pH is useful in proving this disease. And as far as your question is concerned, sir, if I may add, volume reflux doesn't respond very well to PPI therapy, and probably those are the candidates which are they are good candidates for anti-reflux surgery. And although traditionally we used to believe that those patients who respond to PPI, PPI responsiveness is a criterion for surgery also. Now it has been shown that about 30% of patients who do not respond to PPI also may respond to anti-reflux surgery, provided they have a 24 hours pH which shows abnormal acid esophageal exposure.
That's it.
Any other question from house? If there is none, then thank you, Dr. Mohan.
Thank you.